these people to join his organization, and he'll tell you a little bit about it. We're going to give him just 5 minutes, Bill, and then we're going to get started.
In 5 minutes, I'm going to knock off all the bullshit and get to the essence of what we had to say last night. One of the, started with some of the members of the Academy down in Los Angeles talking. The reason that dentists are getting pilloried by boards and courts about their standards is the courts don't care what your standards are. They just want to find out what they are and they'll apply them. And right now, there's only one set of standards that they got, the ADA standards. That's your fault. You haven't told them what your standards are. You need to tell them what your standards are, so we're going to form an association called the International Association of Dental Physicians, which is successful to the National Society of Dental Surgeons in 1842 that was, broke up in battle with the ADA, and they're going to, among other things, publish doctors' tenets and standards for the type of medicine and dentistry that you generally practice. So we can start having your standards recognized by the courts. The courts will recognize your standards if you will go about promulgating them in a formal fashion. And we would like to get this organization started. We think it's urgent, so we're not going to wait 6 months to do it. That's why during the meeting down in L.A., when I stepped out from the men's room, I got elected to come up here and talk to you people about joining in with them. That's why I'm here. We had a breakfast meeting this morning. Some people, one of the things they want to do is publish the standards. The next thing, the Association of Elected Physicians and other organizations have already started a consumer co-op, and they have a plan, some copies of which are back here. Anybody that didn't get one wants to look at it. They would like to get the dentists to form a co-op so that consumers can come and cooperatively purchase dental care. They have to work out the details. This describes the medical one. The dental one will be based somewhat on this concept that it's going to have to be tailored to the problems of dentistry. Basically, that's going to require some way to get dentists to do services for co-op patients on a time and materials charge rather than the way that it's being done now. We need to get as many people from as many different parts of the country as we can to join in this effort. Not only different parts of the country, different parts of the world. If anybody would like to get involved in this, the new association's executive secretary, Ms. Batchelder, will be sitting back here. You give her your card. If you want any of this material that you got left, she'll give it to you.
Okay, thank you, Bill. Not only should we support Bill's organization and what they're doing, you should also support the American Academy of Biological Dentistry. If you haven't already joined, we invite you to join. These are some of our objectives and purposes, and we need physicians, we need dentists in our organization. This morning, I'd like to introduce to you, you've already met him yesterday, probably I feel one of the leading progressive biological physicians that I've met in the United States, the other one being Dietrich Linhart, will be here this afternoon, Dr. Bill Faber. Bill runs the Milwaukee Pain Clinic, and he's doing a lot to spread the two therapies that he uses in the main, which is reconstructive therapy and neurotherapy. But he does nutrition and homeopathy and all the rest too. Bill, come on up and you can get started with your presentation, please. You want to use this?
would you translate for me? My Midwestern accent probably won't be understood. This man, you can see is lying there. He's got his hand over his head. He's got acute kidney pain. History was that he was in several severe car accidents and ran into a tree at 50 miles an hour. So this is over 20 years earlier. Also ran off the road. He had a drinking problem 20 years ago.
Just a second.
He ran off the road 20 years earlier also under some boulders, and it caused going again about 50 miles an hour, caused some considerable jarring to his body. He hit his face against the dash in one of the accidents.
You want the sound to come through on this?
It's okay. He had costovertebral ankle tenderness on Murphy's side of the right kidney. I did a spine series on him initially because the kidney problem wasn't acute. I started him, and 3 weeks later this kidney problem came up. On initial spine series, I noticed that he had ptosis of his right kidney. It had calcified and it was dropped. So he called me. We want to catch this baby.
Okay, we're back. We've done
Just did neural therapy.
Kidney capsular injections, basically. How do you feel?
100% better than when I came in here.
Okay. So the plan is, this has been about, actually about 45 minutes after the treatment. It seemed like, seemed to get relief. How quickly?
Oh, pretty quick. Seemed like right after the injections, that pain really subsided. I had started to diminish a little bit before the injections, but after the injections, then that's gone.
So it's really big time with the injection.
Yeah.
Okay. Are you hungry?
I might be a little later. I'm just tired.
Because you've been up since,
5:30 this morning, I bet.
you haven't ate anything all day? Now, I think significant is that we've had two severe car accidents, and when you were 19,
Why don't you advance it a little bit?
and you went over this very rough,
So basically,
with
acute kidney
boulders,
pain.
you stayed for 500-600 feet.
We injected the
Tell me when to stop.
segment, but then when we injected the kidney capsule, he had an immediate lightening, as you can see on the film, before being crossed straight, and now ready to go. We had to repeat him in a week. I did basically the same thing. This is an interesting one. And then the last time I did a visceral manipulation and the problem resolved, didn't come back. Now this lady can't walk without crutches, and with all my electronics, the sound doesn't come through. But here's the before. That's her best and fastest walk with crutches. She's just going down the hall of the clinic. That's the actual time. Hers is actually more acute in that she's been laid up for about a week, not being able to walk without crutches, having considerable pain in her legs and low back.
Okay, here is
Here's
Leona
the actress.
back. We've done some nerve therapy on her, and she's going to make a statement. There's no crutches. She can stand on it. She's got a cute smile on her face. Stop right there. So what do you think? Good. Good.
Oh, I tell you, that was terrible. I couldn't even step on it, you know?
One thing that's interesting, and Dr. Brock here from Hawaii witnessed this, is that we never really touched your hip, did we?
No.
We did up in your head,
Yeah.
and we did something in your foot, and then we did your belly scars, didn't we? Because on examination and talking to you, the hip seemed good. So I said to Dr. Brock, let's not do the hip. Let's do everything else. So what we're going to do is we're going to walk you around here. You're going to have some herbal tea, and you can go to the post office, whatever. But I just want you to try this out. You can go up and down our steps if you want, because I want to make sure this is really, really good. Another reason is that I'm leaving about Thursday noon, and I won't be gone till Sunday. So you better be fixed. And we better get it taken care of, because I don't want you to be hung up. You go with other doctors and spend $2,000 worth of tests, and you won't be fixed. So keep trying it out and show your teeth. So if you don't have a
Let's stop there. Well, let's see this one. We'll see this one and then we'll start. This is an interesting one.
Mr. Lastly has had severe problems with his knee since 1983. He had an arthroscopic surgery in 1987, got him off crutches, but it lasted about 2 years. And when we did walk down the hall, we'd like to film this nice gig that you got here.
We'll go front. I'll walk forward, and you get my back, and I'll walk back to you. Is that correct?
Right.
Okay. Tell me when.
Here you go. Okay, notice the hand and there. Like that. There he goes. Come on back. Notice how slow he turns around. He sways. And there he is.
Let me get my...
Still here. Well, you go down there. Now let's just go down there as good as you can. Just on the regular walk. Everything go one step at a time. Okay, well, come on back.
Well, after you go to the bottom.
All right, well, let's go to the bottom. Everything one step at a time, not all the way. Just going like a little baby, going down. And then it comes down. Oh, he tries alternating. Just comes back, goes straight there.
What's the answer?
That right leg.
They have to go out.
And that has to go out.
Yeah. I can't just go straight.
Okay. We'll have some pressure put on that leg. I'm getting tired now.
I'm tired.
Just strength.
Yeah.
Here's Bill, he's just been injected. Just come out of the room. Watch him come now.
I have played with you downstairs, but like this little player.
Keep going there.
Believe it.
Not perfect, of course, but the thing that I was experiencing before trying to do that is unbelievable.
What you say is unbelievable?
Yeah.
Well, you better believe it. You went down, didn't you?
I'm all fighting. Look. See, I was before I had
Sorry,
to
slam
get
like that.
like this and bring the foot in.
Keep going.
Now, I
Let's see how you are at the end. Remember last time at the end, he was really
straight up. I come straight up. It's unbelievable. Wait till I feel this to clear.
Take down the straight one. Okay, now come on back, Bill. Okay, so look in the camera here. Well, what do you think of that?
I think it's fantastic.
How about the pain there?
The pain is absolutely minimal.
How about the injection? Was that pretty bad, or what do you think?
No, the injection was nothing like I thought it was going to be, but you know, I was a little looking at the needle that long.
Understood.
Hey, stop right there.
It's not going to aid.
Okay, can we have the lights and the slide camera? These are just the... I didn't know that I was going to have such a wonderful 2 days of introduction. So my audience is very well prepared because we're going to go through basic concepts, basic science, basic research, and then clinical application concepts all in a very short time in both lectures. So it makes it a lot easier with the excellent presentations Dr. Avaretto and Dr. Dukey gave us in his last couple of days. But basically, I think this is where we're starting, in that our this is the triangle of health. We are supported and we stand on our structure. We are fueled and replenished by our biochemical system, and we are monitored and directed by our neural system. So it's basically in physical planes, it's all three of these are working all the time. We've had excellent presentations on the biochemical, we've had some excellent introductions to the neural. We've kind of neglected the structural, but we'll get into that somewhat in the second lecture. So next slide, please. Basically, speaking on the neural aspect, this is something that came out of me from just looking at patients, in that we need to find them on the troughs, right at this lower level, it seems like, to get our best success on their attitudes and their desires. So this is a sine wave, a single sine wave. We catch them where they're mad as hell and can't stand it any longer, right at the very bottom. Then they're ready to go into this, what I labeled the zone of desire, and start climbing out. They've reached their tolerance. They're either going to make the decision they're just going to go out and die, or they're going to start getting better, and they're going to start taking responsibility of doing that. So this green area is all that zone of desire. When you get to the top, well, that's somewhat like the Mike Tyson. You know, they're on the top of the world and everything. You start to fool around with movie stars and everything. You let your guard down, and you start going into the zone of tolerance. Or you could call it the zone of comfort. Things aren't going maybe the best in here, but they're comfortable. It's good enough for them. I mean, after all, everybody else doesn't have it, sorted by other people. They're not at that level. And they're not really ready to make changes and progress until they reach this bottom again, which would be over here, the critical turning point. They're at the bottom of their barrel, and they're ready to start making progress. So we spoke about it yesterday, but I think this is very important to judge where your patient is on this graph and then act accordingly. Maybe if you catch somebody that's actually here and not really ready to go up, sometimes time, tincture of time might be the treatment. Wait till they get a little bit loose, a little bit worse, and back off, and then you can start on it. I think this is the basic psychological desire, is that they gotta want more. Why did you come here? You want more. That's right, you're gonna need more and more. Two hardest things in life. Number one, to change your personality for the better, or to be a parent. This is from a speaker we had at the clinic, Fred Coffey, MA. So health should be easier, because we may have to change our personality for health. And parenting, I guess that's all the time. A wise man changes his mind, a fool never. So how do we get to our goal on the mental plane, the path to success? Well, first we have to have what I call the gotta wanna. We have to have the will, the desire. Second is, as Dr. Dookie mentioned yesterday, we have to have the knowledge. We have to know where to go. We have to have a map. Third is, we have to put the pedal to the metal. We have to take action after we have our knowledge and will. And then we stay with it, and success will follow. So we have some basic rules. One of the rules is each of us are only responsible for one body and one mind and one spirit. We can influence others, but in end result, we're only responsible for one person's health, their mind, and their body. Part of the problem to learning new concepts is when we start to walk, when we start to learn the elements of the world, we find that being right is associated with pleasure and absence of pain, maybe gaining benefits. Whereas wrong is that's when you get the bruises on your forehead when you start to toddle around the furniture. And so we associate being wrong with pain. But actually we should look at it as just like our muscle testing or our ball. It's either a ought or a one. So both things have equally important information. It's just that through our indoctrination to the world, we associate wrong with pain and bad elements. And I think this is a interference field to learning, is this concept of right and wrong. We always have to be right and wrong. And wrong is bad, and good is the best, and we want to be good all the time, or right all the time. So the psychological positions are collateral to the previous concept. Was we find that we're wrong, we say, oh, and there's an explicative in there, usually colloquialism. It's there, you can fill in the blank, and we're wrong, it's bad, it's wrong. But actually it should be, aha, when we find something doesn't work, as well, it's not in that category, it doesn't work, that gives us information. Go on to something else, and this is why neurotherapy is so incredibly exciting, because we get these answers when we plug into the body. Nobody claimed these laws, so I decided to put my name on them. Faber's Law of Justice 1A. Everything happens for a reason or reasons. Nothing just happens. In medical school, they said, well, some people walk around like this. In fact, the whole family walks around like this. That's normal for the Fabers. They all walk around like that. Well, they all walk around like that. That happens for reasons. And we'll get into it, that there's a whole spectra of reasons or levels. Actually. Faber's Law of Justice 2A. I'm good at claiming laws. Everything, everybody is exactly what he, she, or it should be. So in other words, if they're walking around like this, that's how they should be. Because that's where they are in this moment of time and space and knowledge and development, toxicity, etc. Next thing. Your body is like a book. You do something good for it, you do something bad for it, it writes it down. Dr. Dookie brought up these engrams, holograms. You might not know that you've done something bad, but it's in there on some of those pages of that book of your body. It's like a computer. Chronic pain and illness are like an iceberg. In answer to your question, why did we stop with Rick after we cleared his head a little bit? I said, well, that's only the tip. That's what it's in his sensorium that's coming through. This is your symptomatology. But here's the big conditions that produce that. Pain and illness and disability are like layers of an onion. There's structural layers, there's biochemical layers, there's toxic layers, there's mental and emotional layers, there's neural layers, there's energetic layers, there's injury layers, there's political layers of injury, illness, and disability, for sure, and disability. So your body is very much like a computer, garbage in, garbage out. This we got from Dr. Hoffer. I just customized it a little bit. But we have down here an initiator, and maybe it's a silent thing. Baby falls out of baby tendon. Kid gets up, blinks his eyes, everybody says it's okay. Little Billy made it. Then he learns how to ride a bike and he crashes his bike. He's got a multiplier. Falls off, he's got little scrapes. They say, little Billy's okay. So Billy starts driving a car. Little Billy crashes the car, he's got another multiplier. A little stiff, a little sore, X-ray. He's okay. Then finally he starts wrestling in high school and gets in a bad hold, has somewhat of a sprain, and all hell breaks loose. Got all kinds of pain, all kinds of problems. Well, that's how you get that iceberg effect. Through these different injuries are all there, but they've been able to be compensated. It appears that the body can compensate about 40%, maybe more on either end. From, you might say, what is somewhat unclearly defined as normal, we can be 40% less than that and still be thought of as normal without extra acute vision of the problems, or we also have the ability to be 40% above normal. And so the body has tremendous compensatory factors that we're dealing with and need to be aware of. Another principle is that one can't feel his headache if a brick drops on his foot. And this is a very important aspect in neural therapy and biological medicine, because after you pull off these layers, then they say, well, now my back hurts. I come in here with shoulder and arm pain. They couldn't feel that backache because their head was hurting so much. Or if you do allopathic treatment, you might say, give them so much pain and discomfort in their stomach with the Feldine or whatever, they no longer remember their headache. Which is somewhat like TENS treatment is. Isn't that you're running more interference into the system, whereas here, Dr. Ed has been saying we want to decrease the stress, decrease the interference on the body instead of adding more interference like a TENS unit. TENS unit is really kind of like electric aspirin. Doesn't fix anything, just covers it up. I make an analogy to my patients that when you take aspirin or a TENS unit or some type of symptomatic non-curative therapy, it's like when you have guests over to your house and your bedroom's a mess, you just close your bedroom door. Say, don't go in there, it's really, got a lot of coffee in there, it's really bad. You know, the house appears clean if your living room and your lounge area is clean. You just close the bedroom door, cover it up. To get fabulous results, all the problems must be fixed and functioning optimally. So in other words, Bruce, you need a repertoire large enough to find asymptomatic lesions. And Dr. Abaretto and Dr. Dookie gave a very excellent introduction on that. Of course, it's tremendous repertoire to reduce down to zero defect and get optimal function. Again, compared to the very best, the optimal, and not to the worst. Got to get rid of that garbage they taught you at Albert Einstein, University of Pennsylvania, wherever you went, and work to perfection and not compared to the worst. So there's a spectrum of function, and here's less than normal. Here we have a prostrate individual. Here we have a wheelchair individual. Here we have somebody in crutches and a cane, and here's one of the Vapor family walking in extremely poor posture. And here we have spectrum of function above normal. Jumping rope, jogging, high hurdles, basketball, and of course the crown prince of macho, football. Great. So, to get these optimal results, it's very much like putting together a multi-piece puzzle that fit exactly into the patient's body as precisely and as gentler and kindly as possible. Next slide. So going into neural therapy concepts, which all this previous was, I think. I don't think neural therapy has hard boundaries on it. We have a normal membrane bioelectric potential. Normally electronegative on the outside, electropositive on the inside, and this is the schema for cells, nerves, muscles, vessels, and others. Others would be extracellular matrix. Dr. Abaretto clearly pointed out yesterday. And they must maintain this gradient. First chapter of physiology text is in here. We read it, forget about it. Next. When we have a disruption of the membrane, it reverses the normal bioelectric potential, resulting in dysfunction, pain, energy loss occur. So this is known as an interference field or a focus. And again, it occurs in nerves, cells, muscles, vessels, extracellular matrices. So our charge is reversed and we have a break in the membrane. We can no longer maintain the normal gradient, and the area is firing off signals. It's propagating them to the spine and starting that whole cascade. So what is an interference field? Well, it's a disruption of the normal bioelectric balance of the nerve, the membrane, or the energy flow. It can be caused from surgery, injury, infection, fractures, toxins, dental, and other causes, mental influences, curses, sunburns, freezing. We'll get into that more. It's like a short circuit. Just like if the lights would go out from a short circuit. Okay. Scars are involved to a degree with this. And here are the signs of problem scars. Any color other than pale white which persists after 2 years. Normal progression of the scar is from dark purple to lighter purple to dark red to lighter red to pink to pale pink to white over 2 years. So if you have a scar that's over 2 years old, 2 years or older, and it's not pale white, 99 times out of 100, 100%, I think, really, that scar is an interference field just by passing, it fails the color test. 2, a scar that is adhered to tissues. Life is motion, life is movement. If it's stuck down, it's hard, that scar is an interference field. If there's patch marks or tension lines in or around the scar, that scar is an interference field. If there's any alteration of sensorium, so you can have pain, you can have anesthesia, you can have numbness, tingling, strange feelings in or around the scar, burning, tugging, pulling. Next. Any scar which tests positive using any of the bioelectric testing methods. So the ball, the muscle testing, whatever bioelectric testing method you wish that's positive with that, highly suggested it's an interference field. Any fracture site, bone bruise, puncture, infection site, frostbite, tonsil or dental extraction site must be considered a scar.
Can I have one on there? Dental restoration.
That means they haven't had it pulled out?
No. A dental restoration is a scar.
Oh, on the tooth itself?
That's right.
Okay. Any mole, any pimple, any acne scar, any wrinkle, any vaccination scar or lesion? We should add another one, as expanding this, chickenpox scars. If you're European, they have 2 vaccination scars. If you're Asian, they have up to 6 vaccination scars, I've noted on people. And they can be an active interference field. And this is my favorite one, is any totally asymptomatic scar can also be an interference field. So we need our repertoire very large and our index of suspicion very large. Signs and symptoms of interference fields. Number 1, a stiffness, a pulling, a soreness, a numbness, a tingling, a cramping. Should add to this a burning. Is an excellent sign of an interference field, which slowly or immediately follows an injury, surgery, or other event, emotional, structural, or biochemical toxic event. 2, a loss of function or dysfunction of the body part or organ after surgery, illness, or other event. So if we lose a function after an event, so if we have cramping, loss of range of motion, or sensorium change after an event, a loss of function after an event, or any unexplained acute pain that persists, may be as a result of the interference field. And again, my favorite category, so that nobody can tempt me, is other than that. Okay. Common clinical situations. Abdominal scars cause interference fields, which can cause gas, belching, hiatal hernia symptoms, postural pain. Get a big scar on their belly, and we'll show slides of that. Postural pain, lack of endurance, and inability to boogie. Now this is an important one because I've treated inability to boogie was their main complaint. They had the Bannon steel scar or over ear tube surgery they had. They went back to their surgeon, said it hurts down here. I can't dance. I love to dance. They come in and said, well, I've been waiting for you. Just simply do local therapy, inject the scar, and do it till it totally clears and make them boogie again. But that pulls them down forward, can't boogie as well. Chest scars cause interference fields which may mimic angina, myocardial infarction, hiatal hernia, esophagitis, dyspepsia, even in the chest. The symptoms may be very severe to mild or asymptomatic. Head, dental, tonsil scars, which cause interference field, may cause migraine. Migraine has lost its meaning. Anything that's a severe headache is a migraine. By doctor definition, too. Can cause headache, can cause visual disturbances, jaw dysfunction, pain, paralysis, weakness, tics, spasms, personality changes, dysfunction in the head, ringing in the ears, loss of hearing, visual changes, ptosis, right? Paralysis, right? That's a type of ptosis, of course, in the head and the neck. Circulation or organ interference fields. Remember, red blood cells, vessel walls, organ cells, muscle cells must maintain a normal bioelectric balance. Disruption causes interference fields. How the red blood cell keeps from agglomerating, as Dr. Dookie mentioned, is the van der Waals forces, and that the electronegative charge around the RBC repels another electronegative charge on another RBC. So if you lose those charges on your RBCs, your vessel walls also have an electronegative charge. Then you get agglomeration, rouleau, stasis. And in osteopathic college, where there's stasis, there's disease. So intravenous local anesthetics can help restore the membrane bioelectric potential and eliminate interference fields. This is for the circulatory ones. So the lightning reaction was mentioned. What is it? Well, it's immediate reversal of pain and full return of function. It lasts for a minimum of 24 hours and longer. In the dental cases, the unit case put just 8 hours of immediate reversal of pain. But remember, you only get a few hours out of your procaine or lidocaine anyway. So what you're saying is we get resolution far beyond the pharmacology. And so we're getting physiologic and anatomic correction. The third one is real important. After 24 hours, total or some improvement persists. Very important. Next. If the treatment doesn't last for 24 hours, then we must first correct underlying or metabolic or toxic problems. Dr. Duffy mentioned maybe we didn't hit the beginning focus. We hit a satellite interference field. The body's saying it wants another area. Frequently, there's multiple causes. Like you asked yesterday, I said, look, just give me some more time, I'll find a dozen things in that. You know, they're not evident, but if you have a big enough repertoire, you can easily find a dozen things the matter with all of us. The cause may be structural, it may be biochemical, toxic, emotional, all at the same time. So we can't be monotherapists. We can, we're just going to be less effective. Notice this handwriting. The history on this 30-year-old lady was she was in one of Milwaukee's finest psychiatric hospitals, Mount Sinai, for about 3 weeks. And they had pretty much talked into, well, you never got over the death of your mother, and you're depressed because you're 30 years of age, you don't have a regular boyfriend, you're not married, you don't have any babies and stuff. And we're working on giving her the psychotropics and all the other stuff. And in the history, it come out that she heard her brother slammed her hand in the car door some 25 years earlier. She's always had tenderness about her right hand and soreness. So when she came in, I said, great, I've been waiting for you to come in. Next slide. And there's her signature 20 minutes after neurotherapy injection. And that's the way it remained after the, we did a few more, but we got no more improvement in function. It seems like that with both therapies, the neurotherapy and the reconstructive therapy, you tend to get your mother load with the first therapies. I mean, you tend to hit the long ball first, and then you hit doubles and singles until you win the ball game, basically. So I think that's related to a phenomenon that I call maybe the dump truck in the hole syndrome. And that, let's say you have a great big hole, a crevasse. A crevasse is like that, right? So we have our dump truck and we want to cure this hole, and we take the dump truck and load dirt in it and throw it in. And the first dump truck load will go right into the very bottom of that crevasse, and it'll go quite a ways up because it's a lot more slender and narrow at the bottom. And then subsequent truckloads will only fill small amounts of that crevice because it's wider and broader. And I think that's analogy would be somewhat apropos to in the neurotherapy and the reconstructive therapy, why your first therapies tend to be so dramatic. Another thing, as I tell my patients, I say, well, let's say your house is a wreck. There's cockroaches and ants and old pizzas and soda pop cans hanging around and everything. Well, if you just spend a short time and just take out get rid of the cockroaches and pick up the old food and the boxes and vacuum it in an hour or so, people say, well, heck, this is a lot better. you know, your first thing. But then when you start cleaning out the refrigerator, dusting on the ledges and everything, and do a deep steam clean of the furniture and everything, I said, well, that didn't help so much. Well, actually, it is, but it's working at deeper levels, and you have to be a more astute observer to tell the subsequent treatments are actually helping a great deal. Next slide, please. This lady was the first neural therapy patient that I did. She had a fractured neck, C2 through C7, and she went, this is when she was 8 years of age. She was paralyzed with the injury, and she went to a medical mecca and got fused, C2 through C7. She was able to recover about 8 or 9 months. This is when she was 8 years of age. But at about 36 years of age, she developed head, neck, and left arm pain, not allowing her to work for over seven months prior to coming to see me. She went to our one of our Milwaukee's medical meccas, the Bad Samaritan, and they did a myelogram and said she had a herniated disc at the bottom of her fusion, C7T1, and said that she needed to become stick woman. Fused her with Harrington rods throughout the thoracic and removed this disc and said, by the way, you might be paralyzed. She thought, well, you know, I don't know if I want to be paralyzed, so she sought a second opinion, went to another Milwaukee Power medical mecca, St. Lucratives, and St. Lucratives evaluated her and told her much the same thing. You have a herniated disc, we need to put these rods in here because this is unstable at the base of your fusion. So she came in and saw me, and I said, well, I've been waiting to see you. So we explained to her that we wanted to first do a nerve treatment, the neural therapy, to treat her old scar, and then we treated the transverse processes of 5, 6, 7, and T1 on both sides. And immediately she had a light. Well, she asked me if she was going to be paralyzed. I said, well, did you see other people coming in out here? Did any of them look paralyzed? I said, they've been treated in their neck and their back. And I said, well, you could be paralyzed, but it's kind of like a meteorite could come in from outer space and kill us. You know, and that is a possibility. It has happened. You know, but it's not so likely. So anyway, we did the neural therapy and immediately resolved her arm and neck pain. She came back in a week, had a little bit of residual. Came back in a week, had a little bit of residual. 3 times her pain was knocked down. But then I told her, we may have done you a disservice, because although this is Milwaukee Pain Clinic, that's not what we're interested in. We're interested in resolution of the problem. And we advised her to have reconstructive therapy in the lower neck to strengthen that area that was worn out. She never had any disc surgery or anything of the sort, and is doing well to this day. And that's, well, this is our old clinic, so I think it's about 7 years ago or so.
Bill, what again did you do to her? You injected her?
Scar, and then I did the transverse processes of 5, 6, 7, and T1.
What's the lady with the hemorrhage? Where did she get her shot?
She got it in the metaphalangeal area. That's where her hand was smashed. So it's just local therapy in both of them, nothing fancy. We've coined a different term, which is rapid therapeutic response, which is, next slide, which is all the elements of a neural therapy, except you're not using procaine or lidocaine. So let's say you're doing it by psychic means, or homeopathy, or manipulation, or acupuncture. Instead of calling it a lightning, we've changed it to rapid therapeutic response. So again, we get immediate improvement of pain and function. Again, we have the 24 hours, and again, we have a stair-stepping of improvement. Okay. This is a very important slide. A scar can act like a patch on a balloon. It can exert a pulling pressure which can cause marked change in shape and function. So here's our normal balloon. We put a scar on this balloon or a patch on that balloon. We blow that balloon up And this patch controls the entire shape of this balloon now. So in other words, we get a scar, we get talked into having a surgery. In many cases, I think people are talked into it. That's a social thing. People bring in flowers, they brag about it. In Milwaukee, they say, well, I went down to St. Lucrative, and now I'm peeing out of my left armpit. Look at this, isn't this great? And now I'm pooping out of my right armpit. You know, and they're bragging about all the tubes they had in them. It's, I think we got an interference field in our social paradigms. And I bet you it's in your area too. But anyways, if we get a, let's say we get a midline or a phalansteal type of scar, a gallbladder scar, and then we gain weight on it after that surgery, that thing can act like an anchor, and we become a slave to that scar. Our whole body is anchored to that scar, and that scar is controlling everything in our bodies having an effect on it. Next. Another way of stating it, if you sew up a bodysuit and you sew it up, and we rip it and we sew it up again, and we rip it and we sew it up again, it gets tighter and tighter. Even the surgeons know that, particularly in hand surgery. They know that they only have so much room there. And one of their requirements to do hand surgery is have adequate skin. But surgeons, because, well, you know what, I was taught in medical school, the dumbest ones in our medical school class, we call them, we make them surgeons. Now, Dr. Susser said, you know what the definition of orthopedic surgeon is? I said, no, what? He says, well, somebody's as strong as a bull and twice as smart. So you're getting an advanced concept which is not understood by the masses of surgeons, but we simply run out of space. We have a finite space of our covering. When we get more and more surgeries or sprains or burns on it, we just get so tight we don't have any room in our body. A scar, this one's 20 years old. See the color still in it? See how it's adhered down? See the patch marks on the scars? See the deviation of the umbilicus? It's not midline anymore, is it? It's also a hernia in it. Here's a nice one. Deeper here on the herniated umbilicus. Color in the scars. Obviously adhered. So these are definitely interference fields. Now here's one. Can you see it? The interference field? Okay, next slide. We did this one yesterday, so you go up and you get the patient laying down, and you look for boogers, as they say. You can see the mark asymmetry. So he's obviously broke his nose. We've done like a total body reconstruction on him. He's kind of an amateur athlete in that, and he's crashed a few times, auto crashes, and let's put what the result was. He could breathe tremendously better just doing the nose like we did on the lady yesterday. Oh, we've done crowns. Almost every square centimeter is touched by a needle. I don't prefer cranial osteopathy. It's too slow and too cumbersome, and they talk too much. It's kind of like going to an acupuncture seminar. They're too windy. When you do a thorough neural therapy to the head, and I've had somebody who's been one of the best cranial osteopaths, they're going to get over a year's worth of cranial osteopathy in minutes. Okay, because you're releasing all these adhered areas, normalizing the nerve flow, just right then. You better believe it. You get a tremendous cranial effect. And it's hard for me to, I like to have it done, but it's hard for me to go and sit there 45 minutes. Tap into that rhythm. This is fine, but come on, I want that guy, I want it lightning, damn it. I don't want this. And they say, well, come back, it's going to take about a year and a half. Jesus Christ, let me handle it. year and a half, about a year and a half, I can reconstruct their entire body. They work with me 2 to 4 times a month.
Bill,
Yeah.
have you ever treated, let's say, a single scar to the point that it completely disappears?
They always get better looking. And that's one of the, there's very few always in medicine, but that's one of the things, and that's why I think that neural therapy is more structural than what it is biochemical. I don't doubt that it's biochemical or bioelectric, but I think it's more structural. Structure, we stand on our structure, we're fed and fueled by our biochemistry, and we're directed and monitored by our neural, but we stand on our structure. So structure has trump, I think, over the other two. That's the base of the triangle. But yes, they always get better looking, and sometimes they nearly disappear. I never promise a disappearance, but they always get better looking, nice looking, better feel. It just happens.
Well, but my question was directed to actually trying to achieve that, as let's say an endpoint.
Well, I'm going to get into that, but I'm going to be adding proliferative elements, because remember, a lot of the scars, as you saw in some of them already, got a dip. And so I'm going to add proliferative elements in the future. And I got a few scars myself where I went through windshields and tried to crack concrete. And I got a chickenpox scar, and so I'm going to do myself first. And what I'm going to do is I'm going to proliferate below the scar to bring it up, get rid of the shadow as well as do the scars. One of my goals, a couple of them for this year, start doing beauty treatments on myself, see what happens. Okay, go ahead. Need a sledgehammer, I know. Adhesion from the surgery, color present, stuck down. This is, now we're into a section called naval medicine. But this one, that's an innie, and those are good, but it's asymmetrical. See, he's going down here at 8 o'clock, he's coming up here about 2:30. So that would suggest that there's forces or torques down here, over here, a combination. These are vectors, of course, so it's more than one quality, direction and magnitude, not a scalar function. Doesn't tell you where, but it just says, hey, this guy's got some torque in his body, look at that. So this is what we're talking about. You pull down here, symptomatology is at the end. And that's why I think the head and the feet are so important. The ends are going to get the worst. Just like I said yesterday, if I throw Peter a rope, and that rope's hooked to him, and I lean back, Peter's got to resist or fall on his face. And the result of most of that problem that he's going to manifest is going to be at the ends of his rope, of his body. Since we're all hooked together, we have a communication, our feet have a communication with our head, it's going to be at the two ends. Right? This lady's an MS patient, and after doing a neural therapy on her for the first time in years, she could get her leg up this far. This lady had cervical spondylolisthesis to such a great extent, if she brought her head back, her arms would go numb. She could not walk without the assistance of 2 people, one on each side. It took about 20 minutes to load her onto the table. She had been advised by some of the greatest authorities in Wisconsin that she needed an immediate cervical fusion for this instability. Had a CAT scan to demonstrate it. Her husband said, "Doctor, can you do something now?" Well, I had a CAT scan to look at, and I had the myelogram to look at. I wanted to look at a plain film. And he says, "Well, can you do something now?" And I says, "Okay." He says, well, I'll leave and come back." I said, "No, you want something now, you're going to watch this." If you have somebody supporting you and they watch it, it helps the healing of this individual if they're supportive. So we did what we did on Rick. We just did a neural dural release. Immediately she could walk with no assistance. Immediately better with just a dural release. Well, think about it. You're going to have a pull on your dura, you got a cervical spondylolisthesis. And then we did the reconstructive therapy on her neck. In 4 months, she was back to work. No surgery ever. This was several years ago. Next. So that'd be a rapid therapeutic response. This is one of Mayo's masterpieces. Mayo's within 6 hours of my office, so I get a lot of their very excellent work. Of course, they're the best in the world. This lady they decided to do 14 knee surgeries on. She had a total of 16. Why this looks so weird here is because that's her rectus abdominis muscle. They took it out. They sacrificed it out of her abdomen. This is the 13th or 14th operation. Anyway, if she would flex her knee a ½ inch, she'd scream. This was her first visit. As you can see, she has this type of wheelchair, so she can be stick woman. You transfer this person out of the car with their leg out, and see how easy that is. She's only 115 pounds. That's obviously an impediment to mobility. She also had gas and belching after they did this rectus, put it down on her knee. They're Mayos. They're entitled to do these abominations to the body. Just ask them. They'll tell you they're good at it. And they are good at it. She had gas and belching. We did a neural therapy, and this tissue is just hard as hell, just like a rock. Well, only 12 operations. Excuse me, only 14 operations. She's in chapter 15 of the book. But doing a neural therapy first, to all this, about 10 foot of scars, it's unbelievable. We can count her belly scar. And this, immediately she could flex her knee so that we didn't have her stick woman. But she has an underlying cause of rheumatoid, which Dr. Alvaretto says is very difficult. Here's another view of it. I needed one of those cameras that, because it's really uglier than what it is here, because you're getting some flash effect. Look at the huge deformity they made. Well, she had, the knee was destroyed. So several of them were by the rheumatoid, so they did metal implants, which is in the orthodox literature, by the way, that it causes cancer. There's an article on June 12, 1989 in Forbes magazine called Asbestos Again. And it was just a one page. It was written by a doctor for Forbes, and they said that they're suspecting that the metal corrodes in the alkaline medium of the body, paralyzes the enzyme system, decreases the immunity, and causes cancer. Well, I would give this to my patients. I'd copy it out and say, I think you should read this. And they'd come to me with implants in them. The big ones, not just these little things, great big ones. And some of them were going actively to orthopedists still. And one of them brought back what the orthopedist, the American Orthopedic Association, made a statement that says what? What they always say, there is no evidence to show this, right? No evidence, right, Ben?
No
Okay.
reputable.
No reputable evidence. So that's right. I met the How Medica man after meet him at a party, and I said, what should you charge for those things? Up to $15,000 for a custom, just for the damn implant. And I said, are you familiar with June 12, 1989 Forbes magazine article? He says, yes, I am. And that doctor has been discredited. He was really a slime ball and all this other stuff. So on my own, and I says, yes. And I said, I've read what the American Orthopedic Association said in counter to it. And I said, they said nothing. You know, I said, those bullheads said nothing. So I did my own search. It's in the peer-reviewed literature. It's in there that they suspect is causing cancer. So spend some money and do searches. When it's on Medline, it's peer-reviewed.
What they call it is benefit to risk ratio. All the benefit to the doctor, all the risk to the patient.
I need a slide for that. Okay. Here's slides of a lady that went through a windshield. Next slide. She just had a little plastic surgery. Go ahead. Slight laceration there. Anyway, you get the idea. Here she is 6 months later. This is 20 years ago. Go ahead. That's just 6 months later, of 20 years ago. Okay. Anyway, she had a lot of pain in her hip, and her, particularly her hip couldn't lie on it, couldn't sleep with it. We did local therapy, reconstructed her back, etc., went and reconstructed her hip. Wasn't until we got into the face, which you can barely see at this time, that really lifted the whole thing. So I think you're like a marionette. You know, the strings are pulling down here on the hip, but she obviously had a big focus in her head. And if the patient says, no, no, don't go there, that's where you want to go. You might have to ease up into it, but the patient says, oh, no, don't do that. It's just been so tender. Well, that's the art of it, to get them to let you do it. Because that's a big payload if you can get one of those. And of course, you didn't want to taste that histo.
Bill, when you do a scar, you do you palpate where it's tender to, and then you do superficially. Do you do a deep injection as well in the scars?
You go where your body tells you and your intuition and your experience tell you to go. The skin is very beneficial to do it on the superficial layers. But you're perceiving things, it's kind of like fishing, you know, you perceive the end of the hook from way back here. When you go down, if it's hard, that's a good spot, isn't it? So you put your graphites, homeopathic in there, and you put your lidocaine in there, and you dissect. Dissect, I think it's not in the neural therapy books, but it's going to appear in my next book, which is a book on neural therapy, but you dissect those areas. So it's hard softening. This lady is, you saw her on the film, has diabetes, well controlled with about 125, 30 units of humulin and micronase. Well controls her to about 200 or so. Anyway, and she's had it for a number of years, but she developed tingling and numbness of her feet. So what's the diagnosis, Dr. Peter? Diabetic, peripheral neuropathy. So you give her, well, if you're advanced, you give her B vitamins, right? And she was already on B vitamins, by the way. Or you give her Elavil. You know, any trained orangutan can write a prescription for Elavil. Of course, we didn't, well, she was already on the B, but we did neural therapy to her ankle. Poof, one treatment. Gone. Examining the range of motion, we could see that she was getting some loss of range of motion. So dissect the fascial plane. So spontaneous remission, right? Next, we'll do spontaneous regeneration coming up. This is a terrible slide, but a Fannin steel here. And this lady, we reconstructed her knee. It was badly arthritic, but she could not straighten it. She had an angle when she laid down like that. So the kneecap was up. So we got a bigger scope, did her belly scars. Immediately, she had much better range of motion on her knee. Thanks. And there she is. And here's one of our asymmetrical back to naval medicine belly buttons. This man had about 30 years of chiropractic. He fell out of a hayloft when he was in his teens and working mostly in the head, and had another scar up there. Excellent resolution of his 34 years of headaches. This is the biggest one that I've ever done. This woman couldn't sit without pain. She had this scar for 53 years. It remained indented through 2 pregnancies. We got her in the hospital. I said, well, I had neural therapy to live and snot out of her head, her feet, her toes. We just couldn't get her enough space. And we really went in there with a 3-inch at all levels. We just couldn't get her enough space. She went in and they recommended a psychiatrist for her after 2 surgeons saw her. So she came back to me about after 4 months, that very productive admission, and got her with another surgeon that had a little bit of a knowledge that the scar was a problem. And he found that there was a hernia down underneath here, and got her some relief. But that's just this an extreme of what scars can do to an individual.
Bill, can you go back and unwind some of that subcutaneous tissue to give you more of a service area?
Well, I would hope that he would do that, but he's not here at the court. You know, so.
How do you,
But I mean, when he did his procedure, he found her hair gas, so that, is it possible to mobilize your skin for you?
Well, I'd certainly like them to do some, the flapping and the W's and the Z's and everything that they do to produce more space, yes.
So that last one, did I get you right? You said that the neurotherapy didn't work on that patient.
All I could not get a 24 hours, I could not get a stair-stepping of improvement. And so as Dr. Dookie and Dr. Alvaretto state, if you ain't getting on base, you know, get out of that ball game and do something else, whatever it is, you know.
Brings to me, I see in that one shouldn't forget that there could be something allopathic, so something there that you don't want to miss. And that one had a hernia.
The hidden hernia.
Hidden hernia.
Right. So, now we're going into cellular concepts a little
Bill,
bit.
when you have several areas that you're going to, do you have to watch closely the concern about plastic?
No. And that's an excellent question. I think we'll digress a little bit on it because Dr. Goodkey said something, yes, no, Dr. Alvaretto said something, a very excellent discussion on cancer, we're here for the very end of it. On his, I know as an overview, but he said that he hung normal saline and put 5 or 10 of DMSO in and then 5 or 10 cc's of procaine. Anytime they say procaine, translate that to lidocaine and then further translate it to preservative-free lidocaine. Now, it's Elkin-Sin is the largest generic bottler of generics in the United States. My pharmacist friends tell me. So you can get it from your pharmacist. It comes in little 5 cc jugs. Abbott makes it in break ampules, preservative-free, but 2 cc's cost as much as 5 cc. So, when do you worry about lidocaine toxicity? Well, when you get in higher doses. And you'll see somewhere I've used, I use up to 200 cc's on people at a single time of total solution. Now, obviously, that's not lidocaine because it'd be 6 foot under, or we'd have to be running an expensive care unit to monitor them. We either get down or we get up, you know, with that, with lidocaine. So we use my secret formula, which is normal saline, and then we try to get on the dot as much as we can, and we'll use what Dr. Dookie's been talking about, you know, the glyoxal, and that dilutes it even more, and it helps us be more specific. So we use 2 cc's of 1 or 2 cc's. Let's say I get somebody with 10 foot scars, which is not uncommon because we're next to the medical mecca of nails, and they need to cut. Do some heavy healing. So you got 10 foot of scars on them. Well, think about it. Are you going to cover that 20 cc's? Not worth a damn. So I use 1 cc and 9 cc's of saline and or homeopathic of choice. Now, on the saline, I don't use any particular saline. I'm real particular because if you give your patient trash, garbage in, garbage out, you're going to have trouble. And we're next to the largest toxic accumulation of waste in anybody in North America, and the Great Lakes. Our greatest asset is having all this fresh water. Well, this fresh water has been identified to have more than 1,000 toxins in it by government scientists. So think about it. You're in the Great Lakes area, which is a huge area, and you need a piece of bread. Is it going to have Lake Michigan water in it? You need a piece of pie or a cheesecake. Is it going to have Lake Michigan water in it? You know, now they're smart, and they clean up the beer, and they clean up the soda pops because they would get unstable on the cottage shell, but then, you know, with the soda pops in particular, all the garbage they put in there makes it, and phosphate it, screws it up, so it's not really fit for human consumption. But I think that my populace is being poisoned by those lakes. And so I have a more difficult time. I was forced to get into homotoxicology because I noticed that I would just work them over with the reconstructive therapy. And it should be very similar to neural therapy. You should have, pow! Heck of a healing, and you do it. And I wouldn't get it, and I know they were loose. I know that they needed to be tightened up. So that's when I started to get into the detoxification. But anyway, going back to the saline, you don't take it out of those multiple dose clinic jars, a 30 cc, 50 cc, or 100 cc clinic jar, because the government makes us put baby benzyl in there. 1% benzyl alcohol. Well, your headache diathesis people are going to have a headache after they get a little bit of baby benzyl with the saline. And remember, you might be using 150 cc's in most of your patients, 200 cc's, so that could be, they might even get a full cc of benzyl in a treatment. So I take it right out of the IV bottle, because there's no preservative in an IV bottle of saline. A glass bottle, or a plastic bottle, but not a bag. Not the bag, because the bag is not stable, and in parts per, I think it's as high as parts per million of the plasticizers come out of that plastic bag. And you give that to your patient. You know, so if you give your patient a bunch of trash, expect them to have adverse reactions and get tachypnea or the other way, and play anesthesiologist or play cold blue, because in the high volumes you can't have that problem. So it's an excellent thing. And to emphasize what you say is an excellent point, but to emphasize what you say, don't use procaine. Don't use procaine at all on anybody, really. I've used 1,000 bottles of it. I learned it the hard way. And then last year, I knew it for 5 months from my own experience, and then what a doctor said last year. Same damn thing. I'm going a little bit more elaborate on it, but it's the same damn thing. We don't use procaine. We use xylitol, which is, in American language, 1%, preservative-free, lidocaine is what it is. Now, you can use procaine, but you're going to have to pay a lot of money for it, and you're going to have to get the spinal grade of procaine. Well, who the heck do you think you are? I mean, you could do that. Why? You know, the 1% lidocaine is excellent. Dr. Hopper said he used, what, over 3,000 liters of the lidocaine. And
55-gallon barrel.
Fairly well tested. The 1% lidocaine is the thing to use. Or you can use cardiac grade, which is no preservative. It's 4%, so just cut it to get, you know, better dilute, and you can go that way. And I've used carbocaine, yes. And I've used, what are the other ones? I've used marcaine. They got methyl, parabens in there. That's trash. Don't put trash in your patients. You'll get pain, you'll get swelling, it's all from that damn preservative. So I hope that we harping on this. When you go home, you throw away a bunch of bottles. I hope this costs you some money, because it'll help. It'll actually save you money, because you're not going to get as good results with that little bit of garbage in there, the methyl paraben. But with procaine, you got sulfites in there. That's the McDonald's cheeseburger thing. Sulfites. That's what killed them having Big Macs.
The address on the board there is where you can get the xylitol.
That's
Germany.
Germans are like Mercedes. They charge 3 times as much for about a third as much.
Well, if you want to use
So if you want to get Elkin Sins, you get, and that your pharmacist can get you, it's about $16.80 for a 25 flat. Get 25 of these little 5cc junk in it for $16. I don't know what you're getting from these crowds, but I know it's got to be like a Mercedes, you know, $65,000. Why don't you get a Rolex watch if you got to get, you know, really status or something?
I gave my Rolexes away.
Good for you. But that's because you had to sell them to buy the German stuff.
That's why I gave them to him.
I see.
I didn't tell him I bought them in Mexico.
Okay, you're a hell of a guy. Let's get into cell function a little bit. A cell functions suboptimally when it has alterations in structure, in nutrition, in bacteria, in virus, in fungus, in parasites, decrease of oxygen, and toxins. Well, that's very similar to what Dr. Alvarado said yesterday. Next slide. Doctor didn't say this, but this is a very important slide. If a cell that is dead is dead. Dead is dead. So that guy's dead. He's gone. You gotta get him out of there. And the body won't tolerate dead cells anyway. If you have a bunch of necrosis in you, you're gonna make a nice abscess, right? The body's gonna let you know that it's dead. But in most cases of chronic illness, 30, 40, 50 years of disability, we don't have a dead cell, but we have suboptimal various combinations of the previous slide. So what are our goals? To optimize all structures and functions with biological treatment. Gentler and kinder treatment. So here's some cells. There's their normal anatomy. Next slide. These cells have been squished. They have an alteration in structure. When structure determines function, they have an alteration in function. Next slide. So if you want to get them in the right shape, you pump them up with a bicycle pump, wouldn't you? Well, hypodermic is a perfect thing to get that structure changed back from the smash effect. But smashes cause interference fields, conks, bonks, falls. And so think of it in a cellular fashion. This lady's signature was this on 3/29/89. We took it off her informed consent that we do research work. She had a CAT scan proven enlarged liver. She had severe weakness, blurred vision, and unsteadiness on walking. Next slide. We treated her cells with oxygen, and there's her signature immediately after the first oxygen therapy. And it stayed that way in subsequent treatments. Just minutes after 0203, autohemo major blood clotting. Next slide. So that's a rapid therapeutic response. This is the man who fell out of the hayloft. He had asymmetry of his slide. We don't have a before and after, but tremendous improvement working on his head, neck, his neural therapy. Look carefully at this lady's face. Look at this eye. Look at this eye. Look in this area here. She was mugged in one of Milwaukee's better communities, the suburb, and thrown to the ground. Next slide. Now look at her face. Can you go back, doctor? Just for a comparison? Or go back a bit. So we can just show them a comparison. Okay. No, back. Back. Okay. This one, now forward. So, good point. We're working on perfection. That's your goal. But you can see her eyes and her face is considerably changed. Next. So, everybody's got the radio station turned into WIIFM. What's in it for me? So what are the benefits and indications of what we're talking about? The benefits are obtained without any exercise. Can be helpful, but you don't need to exercise for it. The therapy can be effective alternative to surgery, as you saw several cases already. The therapy can be successful regardless of how many years the problem has existed. Therapy is permanent. Any part of the body which has a loss of range of motion better be considered for neural therapy. It is an ACE for contractures, loss of motion, any hardened area. All life has movement. Viola Friedman, but as I recall, that's high school biology. And movement is life. So what are the causes of loss of range of motion? Number one, trauma, surgery, injury. Two, calcifications and or adhesions. Three, fascial torque or muscle spasm. Four, edema, swelling, vessel dysfunction. 5, joint dysfunction can cause loss of range of motion. 6, nerve dysfunction. 7, infection. 8, deformity causes loss of range of motion. 9, combinations of the above. And for Ed, I'll put in a 10, other. Next slide. Calcification was a biggie. Trauma, we know from Wolff's Law that trauma goes to calcifications. We know from Hans Selye in the 50s, the stress of life, that emotional stress goes to calcification. We know from looking at first couple pages of Cecil and Loeb or Harrison's or pathology texts that biochemical stress goes to calcification. What do we look for on x-rays, CAT scans, when we diagnose the big C? And here's kind of an interesting one, which I need to do more research on, but casting, putting the patient in a cast, we know will turn them into a rock. 2, will cause loss of range of motion. So Faber's law of healing. Hoffer didn't claim it, so I put my name on it. But all therapies are really questions. Well, he said neurotherapy is questions to the body, but I think all therapies are questions to the body. Whether it's allopathic, osteopathic, dentalpathic, chiropractic, homeopathic, we're asking the body, hey, what do you think? If we did the right thing, it should tell us. So, we've put this in graphic form, and this is a very important concept, that we start with our baseline of pain and function. We apply a treatment. Let's say it's somewhat of a pleasing treatment, massage, lymphology. The patient says, hey, I'm better. And then after about a week, they're right back when they started, where they started. So this is a no answer because you're right back to where you started. Let's say we applied a more active therapy. Let's say they had arthritis and were a genius and we gave them Motrin like we're taught in medical school. They're better when they take it. The drug fades after 4 or 6 hours or so. And they're down here, they say, hey, I got black stool now. You dug a hole. So that's an extra hard no. It means you did the wrong dang thing. Not only a no, but you're causing some damage if you're down below after the adjustment time. Next slide. So a yes answer could be like this. So we start with our baseline of pain and function. Let's say we did an extraction of the molar. The patient hurts. They're below the line. But in a week, when they should recover, generally this is a 7-day period, they say, hey, I'm just so much better than when I started. Well, that's a very positive yes. Next slide. So how can we bring about these yeses or nos? What methods do we use? Well, we use local, we treat the pain area. We can go remote, as we saw a little bit yesterday. We go with the pelvis, treated the pelvis. And Dr. Alvaretto had her pelvis and her, the front of her pelvis and the back of her pelvis. Already she was noticing that her headache was improved. We never touched her head. Remote or systemic. Homeopathy, intravenous nutrition, oral supplementation, enzymes, herbs, spices, water, Baltic water. In our area, I say distilled or reverse osmosis water is my first recommendation to all my patients, and also 20 minutes of sunlight. We have bad sun. Next slide. So what we're doing is a bloodless surgery. Next slide. Have you heard we're getting instant improvement of hearing loss and decreased ringing? What? Well, some 28 million Americans have presbycusis. Neurotherapy has been effective in hearing loss, tinnitus, and garbled speech. Next slide. This man had years of presbycusis, one treatment, immediate improvement. Okay. This man, you can see he's getting autohemomasia. Here's one of our ozone units. There's his blood. And he's getting the autohemo, but in one of his visits with me, he said, I've had crickets in my ears for 20 years. Well, he worked in construction, so noise is also a trauma. We did the crown and the neurotherapy around the ear. This time I decided, I was in the ozone phase at that time, but I injected him with the ozone, and immediately his ringing was gone, and it stayed gone. And by the way, we got rid of his oak cell carcinoma. At least they couldn't find it. The same place that diagnosed it could not find it. With 28 ozones, IV and rectal, he had 3 inhalations of ozones, and he had some nutrient therapy. Not a lot. And a few colonics. Not a lot. Next slide. This is the very first lady that I did. She could not hear the fingers on the left ear. She had, for 20 years, she had a cholesteatoma surgery. We did a crown, and we did the ear treatment, and immediately she could hear. And the ringing was resolved after a 20-year hearing loss. Well, Dr. Hopper says it's at the attachment here of the ear, just in front of the tragus, just below the lobe in the mastoid process. However, he said a very interesting and excellent thing that that's how you do it in general. But the specific, you may not do it that way. Because you're going to take these concepts and apply them to the patient, and that might lead you to different techniques or additional things. And do a crown, if that's what you wish. Along with it, check them out. You do what you find, basically, and don't beat them up in the process. This man had a basilar skull fracture, fell 30 feet, had ringing. He's not done, but we're stair-stepping, improving his headaches are resolved, let's put it that way, with neural therapy and reconstructive therapy. He still has some ringing, but it's much improved. Next. This lady had roaring. She's much improved. She had a spinal collapse of 3 inches of loss in height. We're doing reconstructive therapy, and she's independent now. My office staff told me to get rid of her because she was just been moaning she'd go up to the desk and go, oh, when she first started coming. I said, look, she's okay. She's okay. She's just hurting a lot. But after about a year of total body reconstruction anyway, she's back with the living, and in the process, we got most of her roaring out of her ear. Roaring, go back to freshman chemistry, and we talk about laminar flow on the tubes on your chemistry table. If you squish a tube, you're going to get more eddy current. So I think that's what we're doing here with the neural therapy for hearing loss. The roaring, the ringing, getting more eddy current, which is good. They open the tube up, take off the clamp.
What's the incidence of clearing up tinnitus with chelation?
It's been reported. I don't know.
Very poor in my end.
I haven't done any with chelation either,
Well,
but it's been reported.
it has to do with hemodynamics, you know.
Well, if you're pulling metastatic calcium out, you're going to have more of a laminar flow and more of a softening. Excellent for fingers, neural therapy. Next slide. Relieving finger contraction. This man, a skull fracture, about a dozen head traumas. He's from Ohio. Ringing in the ears, resolved in about 2 treatments, the ringing of the ears. I sent him to one of my preceptors. He's doing excellent. He needs a total body reconstruction, and he's getting it from one of my preceptors in Ohio. This man had ringing in the ears, several auto accidents causing trauma, and examining his head, he really had a good job, but he had about 200 plugs, hair plugs, from the back going to the front. So treating all those hair plugs immediately improved his ringing. This man spoke in 2 languages, again out of focus, but he spoke in 2 languages that he could hear better after a single treatment. He spoke in Czech and in English that he could hear better. This man was trying to stay away from doctors and doing sauna therapy and passed out. So I guess it's a complication of sauna therapy, and this is a number of years before he saw me. They grafted him from his abdomen to his arm. But anyway, treating his arm allowed his knee to straighten better, treating his arm. Now we did local on the knee too, but we were doing the neural therapy, dissecting this cup grafted area that allows him to straighten the leg. Go ahead. And it was immediate.
So when you dissect, when you dissect a large area like that, quit volume, where you talk about using.
Well, as I mentioned in Jerry, you might use 200, but you gotta go real dilute because you wanna stay under 25 would be ideal. Now you can, according to the book, go to 50 or so. 7 milligrams per kilo. How about if you're big and fat from Wisconsin cheese and we're about 300 pounds? Put them in a tub and submerge them and then do your calculation, get Avogadro's number, multiply it, and then give them your dose. This lady here had a radical breast surgery and it turned this arm into a flipper, basically. Just totally dysfunctional and painful arm for many years. Her chest wall was like a rock. It just touching any place. So here it introduces another concept. This whole area is like a rock. So I came from this way around the edges. And then, of course, this large area. But then I flipped her over. And then I did around the paraspinal area in a dissecting fashion. Now, why do that? Well, if you're, well, yes, but no. I'm going to explain it a little different. If you have a bed sheet and it's just tucked in so tight that, and it's got some patches on it, some violent activity, I guess, on the bed. So you could go and dissect around those patches to give it some more room so it isn't so tight, the bed sheets. But you can go to where they're tucked in on the other side and say, well, maybe we can get some slack here. And I think this is bringing a lot more light on how the heck we can get these lightnings on people where their feet hurt and we only do their head, for example. And you go to the end of the sheets where they're tucked in. Oh yeah, they're radiators, sure. Oh, they can like a rock. Pardon me? Well, you can use that mic over there had a radiation part on it, so have lab radiation from the catheter coil. C, A, and E, of course, you want to consider. 20 years of headache and neck pain after falling on concrete, the plant she worked at. Just look at her eyes. Look at her forehead. Next slide. See any different? That's immediate. And see, I didn't mark it up. You can tell I was working there. That's some of my evidence. She's still crooked as, her head is not straight, but her eyes remain in an instant improvement of ptosis, and her headaches are resolved. We're going for perfection now. And her energy increases. She says, you know, I can mow the lawn now. Before I couldn't even do that. Yes.
Do you do any dental orthopedic evaluations or snapping and shift of the axilla?
I do some of that, and I have one on my film. So we'll see later this morning. A patient was filmed that needed some more height, etc.
How do you measure for
Put tongue blades in. Put 1 in, put 2 in, put 3 in. Better function and better strength, better mobility. Have them do a maneuver with the sticks in and with the sticks out.
Tell if you got a slack or shift there.
Well, I was just doing vertical, but you palpate the TMJ and you treat the neck, which we're going to get into.
Always looking at it in vertical.
And you manipulate the jaw. Well, I'm looking at other components too.
Bill,
Yes.
on the osteology underlying the skull, you look on the outside and the person looks pretty symmetrical. You take the frontal and you look at it in the bone, and the bone bearings are just totally different. In other words, we have to go back to the time that was forming to make it perfect.
Right.
Don't ask me how to do that. Maybe just neural therapy for forming children, you know?
Well, the history and the principles we've been talking about, I think, as you could see, has made a marked difference in a single treatment in this lady's head. Next slide. Here's one. She was on Endodol. Endodol. Inderal. I don't know how anybody with any type of training can consciously give a beta blocker. I could never. We had a whole week on it in medical school, and that's. I went in the early '70s, so it was just released then. And I couldn't buy it after a whole week. So I put this little, and she was incontinent. She was anoretic. Anyway, very screwed up, headaches. Next slide. Slight difference, as you can see, with neural therapy, nutrition, started an immediate tapering down on the Endodol. Next slide. Well, here's our guy that you saw in the film, and you can see he looks very nice there. Next slide. And there's just a snapshot of what you saw in the film with our kidney ptosis. Next slide. Injected his kidney capsule. Basically, all of orthopedics reduces down to two concepts: stabilized or mobilized. What's mobilized? Neural therapy, manipulation, chelation, you're removing calcium. How about those big hairy stools that we want our patients to have, these big logs? I tell them you want to have a stool big enough that you can name. You know, and about as big as a small child. And then we celebrate. Yeah, baptize them. You know. Take a picture of them. But neural therapy is obviously a mobilizer, Walping, massage, lymphology, mobilizing therapies, acupuncture, mobilizing, releasing therapies. Your stabilizing therapies are your reconstructive therapies, splinting, fusion, implant with these stabilizing therapies, although I think they're slightly objectionable. So that's what we're doing. We have to decide to do one or the other, and in fact, how is it really, Jerry? How is it really in a patient? What do we do? Right, exactly right. You have to do both in many people to get all the layers off. Because of Wolff's laws and then concepts we'll go over in the next lecture. Next slide. The worst thing for healthcare is insurance. This is by, how appropriate, we got a DBS quote here. Joseph Phillips, DBS of Eau Claire, Wisconsin, says the worst thing for healthcare is insurance. Because what it says to people is don't do anything about your health. Just wait till you get sick and then somebody else will pay for it. So it's not really health insurance anyway, it's sickness insurance. It has nothing to do with health, it's all sickness. And I'm going to get a little political here and talk for just a second, but I object to your congressmen, your senators saying health care cost. Health care cost. Well, health care is just as big as the military, which is $500 billion also. And we don't speak so sloppily about the military, don't we say Marines, Coast Guard, Army, Navy, Air Force? Don't we have it like that? Well, healthcare cost is also a misnomer, because cost means that the only thing you're doing with healthcare is expense. And so I'm proposing, I haven't introduced it to the, whatever you call the legislators yet, but I'm getting ready. But I feel that we should tell them that we object to that and get a more precise language. Why? Because it's actually, this is apropos to neural therapy, except in another sphere, that in order to get your best results, you target, you focus. When the Wisconsin hunter hunts, he doesn't go into the woods, or he might, and take a shotgun and go boom, 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 in the forest. and say, gee, I hope something good runs into that. Well, how can we hit a goal of reducing health care costs if we use the wrong verbiage? So what's the proper verbiage? Well, I think there's 3 categories that we should get these guys to, at no cost, other than paper cost, to start talking about. One is crisis care cost. That's when you're in that bed there that we showed. You can't breathe, you're bleeding to death, you got a bowel obstruction, your gallbladder is gangrenous, your leg is gangrenous. That's crisis care cost. That's one category. Again, we talk about just that. And its percentage, I guess its percentage right now is somewhere about 35% or so is crisis care cost. The second one is a huge category called sickness, I named it sickness maintenance cost. Now that's the ones where they can go into the family restaurant like the Baker Square in Milwaukee and brag about, well, I went in and went to St. Lucratives today and I got my sickness maintenance therapy. Oh, you got sickness maintenance, good. That's really good. What'd you get? Well, I got some Indidol and I got some cortisone because I got polymyalgia rheumatica. And I got some Theophylline for my asthma. And that's sickness maintenance. Well, people, if you just use the proper term, why is it sickness maintenance? Are any of those drugs curative by the PDR? Do they have an indication saying they're curative? So that's how you tell. Is it curative? You can hook it into this yes and no. If they're taking them long term, is that a yes or a no? It's a hell no.
What it is side effective.
Huh?
Side effective.
Yeah, it's side effective.
It ended all.
Drugs work, and they're side effective. And the third category is health building capitalization. Now, what's health building? Taking homeopathy, getting colonics, doing visualization, meditation, neurotherapy, curative things, where you get a yes answer. Health building capitalization. Why do you have to say capitalization? Because health building is an asset, and you must use a proper target to get the proper answer. You have to have proper focus. Cost, in accounting terms, is an expense. But if you take cash and buy an asset, that isn't on the income and expense sheet. That's a balance sheet. So that's an asset. So it's capitalization. So if we can just get these jerks to use the right words. Right now they go, healthcare costs, healthcare costs, healthcare costs. Like everything's bad in healthcare. Well, if we can get them not to say healthcare and say, well, you're talking about crisis care cost, sickness maintenance cost, or are you talking about health building? I think that's the first step to see. Right now, they're like the Wisconsin hunter, and you're just shooting around in a 360 in the forest, hoping that something good will result. Next slide. Health insurance care actually equals sickness crisis care. So they won't pay for your oil change unless you crash your car, right? With your car insurance. Well, it's the same like health insurance. You know, if you need your leg cut off, they'll pay for it. If you want a stronger leg, like going to Big County, they won't pay for it. Next slide. So really, self-choice health care equals health building, or people exert their personal responsibility and exert their choice and focus. That's when you create the asset. Next slide. If you don't take responsibility for all that happens to you, someone or something or a legislator will. Next slide. So life is basically choices, and we have to decide what's important to us. And I left off one for Dr. Spade. I left off sports, which we should put way up here at the top. That's very important in this society. And then, of course, our cars, our monies, our TVs, our loved ones, or our house are also assets. We're almost done it.
I know.
Be careful of your language, your patient language. If they say can't, that is not equal to won't. Okay? They use I can't, but they actually mean I won't. So we must be very careful on how we use our terminology, because what we think about we get. But remember the can'ts, won'ts, and to's. I'm too stupid, I'm too fat, I'm too whatever, I'm too weak. They never lead to success. Can you have a tremendous victory without a struggle? No other device delivers such precise medicine and therapy with such minimum trauma than the hypodermic. No other device has saved more lives and relieved more pain than the hypodermic. In closing, watch your thoughts. They become words. Watch your words. They become actions. Watch your actions. They become habits. Watch your habits. They become your character. Watch your character. It becomes your destiny. So, in summary, remember it's nothing for nothing. I'm giving you the rules. It's a tip for a tat. What are you doing to build health? Are you doing any structural reconstruction? Are you doing any detoxification? Are you doing exercise? Well, those that are here obviously doing learning. Are you working on improving your emotions, meditation, Tai Chi? Are you taking natural, whole, raw foods, as Dr. Avaretto mentioned? Are you taking distilled or RO water? Or are you going the other way and taking soda pop and tap water? Invest in yourself. No trade-ins allowed. When you trash your body, where are you going to move to? Everyone, everything gets what he, she, or it deserves. That's an advanced concept. So what do you want? And thank you very much.
Thank you, Bill, very much. I enjoyed that immensely. There's an old axiom I used to kind of ponder over. They applied this to dentists, and it went something like this. I think Bill is, we can apply it to physicians too, and I think Bill is going to prove this axiom wrong. And the axiom went something like this when it was applied to dentists. The reason why there are no good books written by dentists is that dentists who can write don't know anything. Time to take a break.
Money.